So again, welcome everyone. My name is Alan Tipa, and I am the director of the Center for Women's Reproductive Health. I see quite a great attendance online, including colleagues from outside of UAB, which is fantastic, and some of our colleagues from the American Heart Association Health Equity. So welcome everyone. As people continue to come, we will go ahead and begin with some introductions. As you know, this is a seminar that's jointly hosted by the Center for Women's Reproductive Health and the Hypertension Research Center. We are both centers really delighted to have Dr. Sanchez here today from the American Heart Association. As you know, we are beneficiaries of two health equity research networks, one with the coordinating center here at UAB, and the other with on hypertension with a data center here at UAB. So without much ado, I'm going to call on Dr. Paul Monja, who is co-director of the Hypertension Research Center and Associate Dean at the School of Public Health, to introduce Dr. Sanchez. Thank you.
Thank you, Alan. It's my honor and privilege to introduce Dr. Eduardo Sanchez today as our speaker. Dr. Sanchez received his medical degree from Southwestern and an MPH from Texas Houston School of Public Health. I've known Dr. Sanchez a long time, and it's really special to have him here today. So just I promise that keep this short. So just a little background. So Dr. Sanchez was the commissioner of the Texas Department of State Health Services and then commissioner of the Texas Department of Health from 2001 to 2006. These roles oversaw a wide range of programs, including areas focused on health disparities, diabetes, tobacco cessation and control. He also led the response for ensuring the health and safety of tens of thousands of evacuees from Hurricane Katrina who wound up in Texas back in 2005. Currently, Dr. Sanchez serves as the Chief Medical Officer for Prevention at the American Heart Association. He is the principal investigator of the National Hypertension Control Initiative, and he's also a co-author on the 2020 Presidential Advisory from the American Heart Association for a call to action to address structural racism as a fundamental driver of health disparities. So it's short that Dr. Sanchez takes over.
Dr. Stita and Muntner, Alan and Paul, thank you so very much for the invitation, first of all, but also just this has been a really fabulous day and a half that I've gotten to spend with you, and with the folks you connected me with. A couple of things that come to mind. One, I'm just so heartened that what I saw is School of Medicine, public health, within the School of Medicine, what I would call the OB-GYN department, and then the cardiovascular department, collaborating, and that's just a beautiful thing. I'm a person who believes that collaboration is really, really important. My lived experience is that when I've been able to collaborate across systems and within systems, better things come out of it. And so it's just been really, really beautiful. There's a few things I want to make sure that I do. One is acknowledge a few people that I had the opportunity to have dinner with last night. That was really, really special. Doctors Harding, Hidalgo, Muntner, Sinky, Jakowski, and Tita. And I'm saying last names because I called one person the wrong name the whole night. I'm not going to tell you who that was. One person knows who that was. And all I would say is disculpe. I would say to you that some might say that I have superpowers. My kryptonite is remembering names, and it's been a problem since I was in high school and in college. So not too worried about it, but every now and then I end up in these really awkward situations. And one of the things that I wanted to do before I started, and the name of it, I have a slide in a moment. So maybe I'll just get us there first. I want to iterate the title of this, Start with Health Equity. I don't know about y'all, but I'm in rooms all the time where the conversation is had about, well, maybe we should embed health equity in everything we do, or do we include it in a statement of principle and actually say that's an and not an or, it should be both. And then the other is, I was on in this vein. I was asked the other day on a starting meeting icebreaker to what word do you think of when you hear health equity? And my contribution was start with health equity, and everything we do should start from that place. And I'm hoping that I'm going to talk a little bit about that with you all today. I am the principal investigator of NHCI. I have no other disclosures. Acknowledgements. It is Black History Month, and I'm going to spend just a little bit of time before I get started on that. And it is Heart Month. And I put parenthetically, this is Eduardo Sanchez speaking of the American Heart Association. We should be talking about heart health and heart health month. Another acknowledgement is Drew Mills. Drew Mills is somebody who works with Eduardo Sanchez at the American Heart Association. And what you see is largely his work that helped me seem like I am prepared when we get started. Black History Month, there's two people who are personal heroes of mine, people who have and still continue to shape how I think about issues. David Satcher is one of those people born in Anniston, Alabama, and Regina Benjamin is another one of those people born in Mobile, Alabama. And I've had the great privilege in my life to know them, to interact with them, and still learn from them when I have occasion to interact with them. Other thing that I wanted to do was read from Martin Luther King's last speech delivered April 3rd, 1968. Not the whole speech. There's two parts of it that I think are germane, both to Black History Month and to Heart Health Month or Heart Month. And these are his words. I remember in Birmingham, Alabama, when we were in that majestic struggle there, we would move out of 16th Street Baptist Church day after day. By the hundreds, we would move out. And Bull Connor, y'all know who Bull Connor is, would tell them to send the dogs for it, and they did come. But we just went before the dogs singing, ain't gonna let nobody turn me around. Bull Connor next would say, turn the fire hoses on. And as I said to you the other night, Bull Connor didn't know history. He knew the kind of physics that somehow didn't relate to the trans physics that we knew about. And that was the fact that there was a certain kind of fire that no one could put out. And when we went before the fire hoses, we had known water. If we were Baptist or some other denominations, we had been immersed. If we were Methodist and some others, we had been sprinkled, but we knew water. That couldn't stop us. And we just went on before the dogs, and we would look at them. We'd go on before the water hoses, and we would look at it, and we just go on singing, over my head, I see freedom in the air. And then we would be thrown in the paddy wagons, and sometimes we were stacked in there like sardines in a can. And they would throw us in, and old Bull would say, take them off, and they did. And we would just go on in the paddy wagon singing, we shall overcome. And every now and then we'd get in jail, and we'd see the jailers looking through the windows, being moved by our prayers, being moved by our words and our songs. And there was a power there which Bull Connor couldn't adjust to. And so we ended up transforming Bull into a steer, and we won our struggle in Birmingham. Now without injunction. We have an injunction, and we're going into court tomorrow to fight this illegal, unconstitutional injunction. This is in Memphis that he's talking about the injunction. All we say to America is be true to what you said on paper. If I lived in China or even Russia or any totalitarian country, we now use the word authoritarian country, maybe I could understand some of these illegal injunctions. Maybe I could understand the denial of certain basic First Amendment privileges because they hadn't committed themselves to that over there. But somewhere I read the freedom of assembly. Somewhere I read of the freedom of speech. Somewhere I read of the freedom of press. Somewhere I read that the greatness of America is the right to protest for right. And so just as I say, we aren't going to let dogs or water hoses turn us around. We aren't going to let any injunction turn us around. We are going on. I read that to you because in my mind, Martin Luther King is one of the single most important American heroes of our time. If there was anything that, if I could magically make it happen, at the very least, it would be added to the faces on Mount Rushmore, and if not, he'd be the only face on Mount Rushmore. My child was named Francisco Martin for Martin Luther King. And the last thing I'd say is that although this was 55 years ago, it was 55 years ago. I don't know who else is as old as I am, but I was alive 55 years ago. And there are people in this room who wouldn't be allowed in this room 55 years ago. And while there is still a struggle to be had, progress has been made. And so I wanted to take a moment to say, we want to start with health equity because there is still a struggle to be had. We still have work to do, but we've come a fair way in 5 years. So I appreciate the time on that. The other thing that I was going to read there is about the Good Samaritan parable. Let us develop a kind of dangerous unselfishness. One day a man came to Jesus and he wanted to raise some questions about some vital matters of life. At points, he wanted to trick Jesus and show him that he knew a little more than Jesus knew and throw him off base. Now, that question could have easily ended up in a philosophical and theological debate, but Jesus immediately pulled that question from midair and placed it on a dangerous curve between Jerusalem and Jericho. And he talked about a certain man who fell among thieves. You remember that a Levite and a priest passed by on the other side. They didn't stop to help him. And finally, a man of another race came by. He got down from his beast, thinking that's a horse. Decided not to be compassionate by proxy. We got down with him, administered first aid, helped the man in need. Jesus ended up saying this was the good man. This was the great man, because he had the capacity to project the I into the thou and to be concerned about his brother. Now, we use our imagination a great deal to determine why the priest and the Levite didn't stop. At times we say they were busy going to a church meeting, an ecclesiastical gathering, and they had to get down to Jerusalem so they wouldn't be like their meeting. At other times we would speculate that there was a religious law that one who was engaged in religious ceremonies was not to touch a human body 24 hours before the ceremony. And every now and then we begin to wonder whether maybe they were not going down to Jerusalem or down to Jericho, rather than organize a Jericho Road Improvement Association. That's a possibility. Maybe they felt that it was better to deal with the problem from the causal root rather than to get bogged down with an individual effect. But I'm going to tell you what my imagination tells me. It's possible that those men were afraid. You see, the Jericho Road is a dangerous road. In the days of Jesus, it came to be known as the Bloody Pass. And as you know, it's possible that the priest and the Levite looked over that man on the ground and wondered if the robbers were still around. Or it's possible that they felt that the man on the ground was merely faking. He was acting like he'd been robbed and hurt in order to seize them over there, lure them there for a quick, easy seizure. And so the first question that the priest asked, the first question that the Levite asked was, if I stop to help this man, what will happen to me? But the Good Samaritan came by and he reversed the question. If I do not stop to help this man, what will happen to him? This seems to help me appreciate the notion. I'm talking now as Eduardo. This helped me appreciate start with equity. Good Samaritan started with equity in his mind. So I appreciate you letting me do that. And now we'll get started with the PowerPoint presentation. So I've got some objectives. You can read those. This will be available to y'all. There are really more slides and I'm going to have time to talk about. And I'm going to try to touch on one highlight and sort of move on to the best that I can. Our mission statement at the American Heart Association is one that I find really, really freeing to be a relentless force for a world of longer, healthier lives. You notice that the word disease isn't there, the word heart isn't there. And this has allowed the American Heart Association in many ways to be in the space of social determinants of health, structural inequities, way upstream of cardiovascular disease and even modifiable risk factors. So So why start with health equity? Well, let's start with the definition. Health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. 2030 defines it a little bit differently as the attainment of the highest level of health for all people. And y'all know your statistics better than I do about Alabama. I can share with you what we know about health in the United States. And there is no way that we can say that for all people in the United States, health equity has been achieved. People don't have a fair and just opportunity. And oh, by the way, they absolutely have not achieved optimal health. That's been made abundantly clear, I believe, during and maybe even because of the COVID pandemic. Life expectancy in the United States decreased for the first time in 2020, came down again in 2021. And that life expectancy was not borne equally by persons who belong to different race ethnicity groups. And you can see that here, that there is a decline, basically a decline in all of the 5 race ethnicity groups that are captured here. But you can also see that persons who are Hispanic, while starting point was high, that's the leftmost set of bars. The fall was pretty dramatic from where it had been. And then you can also see that persons who are Black, persons who are American Indian, Alaska Native have started at a low point and has gone even lower from a life expectancy perspective. But even before COVID, the American Heart Association and others had realized, had seen the statistics that when we look at things like cardiovascular disease mortality or stroke mortality, there is a difference in the mortality rate. And while what this is trying to depict is that there was more or less a decline in mortality rates in each of the 5 groups depicted here, that decline was not borne equally. And oh, by the way, the end point, the lowest point for persons who are Black with regards to cardiovascular disease and stroke mortality doesn't even get to the levels of the high point of the other 4 groups that are captured here and on both sides of this graph. And I think that it is unacceptable and should be unacceptable that that is the state of affairs, and everything we do should be about bringing all mortality rates down to that lowest level that is appreciated by whichever group is appreciating the lowest level of mortality rate. During the pandemic, as the disproportionality of getting infected, having complications, and dying just became so stark in all of our communities and states, I cannot imagine that it was not the case in Birmingham, Alabama. But also when culminating with George Floyd's murder, the issue of structuralized injustice in this country came to our attention. It was my great pleasure, honor, privilege to be a part of this presidential advisory from the AHA, a call to action saying structural racism is a fundamental driver of health disparities. It's not enough to know they exist. It's not enough to describe them. We've got to recognize or identify what it is that's leading to them and do what we can in the best case to dismantle those things when they're structural. And in the less best case is mitigate the effects of those things once we've identified what they are. One part of that paper was that there is a historical legacy part where not only the historical legacy for persons who are Black in this country is described, but also the historical legacy for persons who are American Indian, Alaska Native, for persons who are Latino, and for persons who are Asian, as broad as that category is part of that paper. The writing group felt really, really strongly that you got to know historical context in order to appreciate what might be the path to resolving these structural inequities. And what I want to have you point attention to is that in almost all the instances, the flow that lands at concentrated poverty and unfavorable social determinants of health is shared across all 4
of these historical legacy descriptions. And that the manifestation of that includes, and I'm going to add one that's not on here, poor access to healthcare, poor housing conditions and physical environment, poorly funded and resourced with people, schools, poor access to capital. And I have to say, injustice in the criminal justice system is one of the things that needs to be called out here. Now, what's really, really gratifying to me as somebody who works for the American Heart Association is that in addition to publishing this presidential advisory, which might have been the way we did it, a call to action, let's go do stuff. The American Heart Association made 10 commitments to address the drivers of health disparities, including social determinants of health and structural racism, and did so in a way where there is a report. I probably failed to have the link to the report. I'll make sure that you have that. But we've done a report, and I'm pleased to say our goal was to have some things done by 2024. And in most, we've already achieved or exceeded the goal that we made very publicly about our 10 commitments in these areas. And I'll move on. One of the consequences of that commitment around research were the Health Equity Research Networks. The first Health Equity Research Network was on the prevention of hypertension. It includes a focus on food for managing hypertension, home blood pressure telemonitoring using community health workers, a barbershop-based program, CLIP, a program that takes the clinic to the community in Detroit with mobile vans, and then Epiphany, which is the part of the Health Equity Research Network that's taking place here at UAB. And y'all know this better than I do, but it is trying to look at and characterize and describe an intervention that uses faith-based communities to affect change. The second Health Equity Research Network on disparities is on disparities in maternal infant health outcomes, called P3, Equate Pregnancy and Postpartum Postnatal Enhancing Access and Quality to Achievable Equitable Maternal and Infant Health. This is the coordinating center for that, led by Dr. Tia, and a tremendous accomplishment and opportunity. And then in addition, providing an optimized and empowered pregnancy for youth POPI is being done here. I've had the great pleasure of meeting both Rachel and Wally, and am excited to know how this all went when we're on the other side, and how we all can learn how, by being systematic about what we're doing, being rigorous about what we're doing, we can begin to understand the things that are making a difference, and how we might go putting those, how we can put POPI in lots of other communities. So I come back to why start with health equity. Well, there's just inequity, and the things that kill us are a reason why we need to think about health equity. In 2019, the number 1 and number 5 causes of death, heart disease and stroke. COVID-19 wasn't even a thought. It wasn't even a thing we could imagine. And then it was so immense that it became the number 3 cause of death in the United States of America. But I would say to you that if you just stop there, and when people talk about this, sometimes they stop there. If you look at the number of people who died from heart disease, the number of people who died from stroke, and the number of people who died from diabetes, there's an increase in every single one of those from 2020 to 2019. And what I say, and I think you will agree, is that COVID-19 not only killed people in its path, but it left a wake of destruction behind it. And if you were that person who suffered a stroke and needed to be taken care of in an emergency room, it wasn't God help you. There was no one who could help you because they were busy taking care of other stuff that was capturing their attention. And if even after you were evaluated, you needed to go to the intensive care unit, Again, not so much God help you, there just was nobody to help you because people were busy taking care of lots and lots of people at COVID-19. And I was talking a little earlier to y'all's colleagues who work with neonatal intensive care units, and even neonatal intensivists were being deployed to the adult East ICUs to take care of what was a never-ending flow of patients who deserved our care and needed to be taken care of. But COVID-19 had more than just an effect by itself and on this. 2021, COVID-19 numbers went up a little bit. They're going to be pretty high again in 2022. I think they'll be down in 2023. We're all experiencing that. And we are all grateful that we are on the other side, that we have vaccines that can protect our populations. And I still wonder how can it be that there are still people who aren't fully vaccinated to protect themselves from COVID-19, because I think when I look at the evidence, those who show up who've been vaccinated are more likely to end up in a bad way than those who have been vaccinated. So I'll stop there for the moment. The demographics of this country are changing. The demographics of the state, I imagine, are changing somewhat similarly. The population is older, more diverse nationally for sure, and more urban. Don't know if that's playing out in Alabama. I think of Alabama as a largely rural state with a couple or three metropolitan areas, whereas I think of Texas, in contrast, as a urban state. I mean, the number of people that live in Houston, Dallas, Austin, San Antonio, and Fort Worth is 85% of our population lives in a handful of maternal infant deaths. I want to mention this YPLL for a moment, because I think that if we get into the, we compare number of deaths due to maternal mortality to number of deaths due to cardiovascular disease, that's not a fair argument at all. We're talking about different segments of the population. We might just look at 18 to 45-year-olds, and still when you look at 18 to 45-year-olds, maternal mortality doesn't rise up to the top 5. But when we look at years of potential life lost, which estimates the average time a person would have lived had he or she not died prematurely, we might think differently, very, very differently about maternal mortality. Of course, it's a tragedy, and every single death is a tragedy. But when we add to that the YPLL, and frankly, the YPLL, if there was a methodology to attach YPLL to children who might have been left by a mother who died, and the YPLL of that child who wasn't born, and the cascading YPLLs of all the people that that person might have touched, maternal mortality is a way bigger deal than the hundreds of deaths that occur a year. It has an effect on hundreds of thousands, if not millions of people. Interestingly, we're a country that, for a country that's exceptional as it is, I sometimes wonder if it isn't exceptionality in the wrong areas. So the U.S. has the worst maternal health and healthcare compared to any of the other industrialized nations, and y'all know the reasons for those. So why start with health equity? Well, I'm not going to try to look at this. I took a little piece of this. This is total number of births, maternal deaths, and maternal mortality rates by race and Hispanic origin, 2018 to 2020. I boiled that down to the 2020 numbers. And there's a couple of things that I think jump out without you needing to look too hard. One, the maternal mortality rate, and this is meant to have live births number, maternal deaths number, maternal mortality rate, deaths per 100,000. So I apologize to you. So 55.3, and I will send you a version that's got that corrected. 55.3, markedly higher than any of the other maternal mortality rates that are captured by race ethnicity. And you can see in every one of these, in every one of the categories, total non-Hispanic white, non-Hispanic black persons, Hispanic persons, the maternal mortality rate goes up with age cohort, under 25, 25 to 39 could be a number. From a different source, these are deaths per 100,000. I wanted to put this in here because the American Indian Alaska Native was not captured in the previous slide. And I think it bears capturing because after non-Hispanic Black persons, the maternal mortality rate for American Indian Alaska Native comes in a unacceptable, also unacceptably high number 2, as compared to non-Hispanic Asian, non-Hispanic white, and Hispanic persons who die in pregnancy. I want to touch on a couple of things that are here. You are probably aware there's references for all of this. There's a scientific statement released by the American Heart Association in the last few weeks talking about pre-pregnancy cardiovascular health, and that it might be strong enough to say will reduce adverse pregnancy outcomes on a population basis and reduce cardiovascular disease. What do we do to improve cardiovascular health along the life course, including pre-pregnancy? As you know, in 2017, you may know, U.S. Preventive Services Task Force recommended screening for preeclampsia in pregnant women with blood pressure measurements throughout pregnancy. There is a draft out there. If you go to the U.S. Preventive Services Task Force website, you can comment on the new draft, which is recommending screening for hypertensive disorders in pregnant persons with blood pressure measurements throughout pregnancy. It's an update of the science, and it's just a reiteration that we ought to be checking blood pressure in pregnant women basically every single time there's an opportunity to measure their blood pressure. There's an interesting study published in JAMA with evidence of subclinical cardiovascular disease in persons with history of gestational hypertension or history of preeclampsia. We know that having high blood pressure during pregnancy can cause challenges to the pregnancy. We also know, and this is adding to the evidence, that having gestational hypertension or preeclampsia increases the risk, and it can be measured of having cardiovascular disease later in life. One thing that I wanted to mention that is just important to me because I'm married to a person whose area of study is depression, and that is that postpartum depression is a thing. And the degree to which we are engaging with women, both while they're pregnant, or before they're pregnant, while they're pregnant, and afterwards, persons who are pregnant, really important that we all be mindful of what could be postpartum depression in an individual, affecting 10%, 15% of adult mothers every year. The U.S. Preventive Services Task Force recommends that clinicians refer people who are at increased risk. And you can educate yourself on the PHQ-9 and even the PHQ-2 as a screening tool to see if indeed that mother has depression. Interesting study that's in Health Affairs, expanded coverage during the postpartum period, comparing a couple of states that expanded Medicaid versus states that did not, showed a reduction in 60-day postpartum hospitalizations, and even seemed to extend beyond to 6 months. And then lastly, a study in the American Journal of Public Health just recently, no surprise to you, but really, really relevant in this state, maternal mortality nearly 2 times higher in rural areas than in urban areas in the United States. So I'm going to come back to poverty and unfavorable SDOH. And I say unfavorable SDOH. I don't know about y'all, but have you come to realize that sometimes the term social determinants of health is used as if it was the thing? It's not the thing. It's unfavorable social determinants of health. Because if you have high educational attainment, that's a good thing. If you have high household income, that's a good thing. That is a social determinant of health. So just a reminder to all of us, social determinant of health needs an adjective to describe it. So I've been trying to use that more and more and break myself of this habit of calling SDOH the thing that it's not. It's just it's a thing that can be rated, and we should rate it. This is a study that I would encourage you guys to have a look at. It's not directly related to the work you're doing. It's intersectionally related to the work that you're doing. And this was a study done by Morgan Health. And if you Google or search Morgan Health disparities in employer-sponsored insurance, the important thing here is this is looking at health disparities in people with insurance, employer-sponsored insurance, not public insurance, Medicaid or Medicare, employer-sponsored insurance. And what I want to, there's a lot of information there. If you're really geeky like I am, I went to the data itself and pulled out some other stuff. But this comes from their report because it pretty much tells the story. There are prevalences to there are financial barriers to care experienced even by people who have health insurance. And when you capture all of those people, 12% have difficulty paying medical bills, 10% have cost-related non-adherence to prescription that can be prescribed, 7% delayed medical care costs due to cost. That's pretty big. But if you go to the next figure, it captures one of those categories by income levels. And what you can see, I don't think it would surprise you really, is that people who are in categories of low income and look at $75,000 of household income per year or less, we're talking about almost 20% of those persons experiencing difficulty paying medical bills. And if you are an employer and you're trying to get into the business of health equity, one of the things you might do is figure out how you might address this. And I don't know what the solution, I do have ideas of what the solution is. But that might be a place to do health equity in your workplace for folks who are at low income. One more thing that was captured by this study, and I had to create my own little table, was food insecurity. And overall, 7.7% of persons with employer-sponsored insurance have food insecurity. But guess what? Level of income, household income matters. And it's, I think, astronomically high. The thought that in this household, less than 50,000, it's up to 1 out of 5 persons. And even at 50,000 to 75,000, it's north of 10%. Ask yourself, who work in this institution, which of the employees who work at UAB and have insurance fall into what part of this continuum, and their lives are pretty challenging. And some of y'all maybe have taken care of people with insurance who are working folk. I took care of folk who were insured by the UT system, UT Austin, and who were janitorial staff or food service staff. And I'll tell you what, their lives were no less difficult than what we think of as being the life of somebody who has no insurance or is on Medicaid. And paying rent the next month was sometimes a challenge. And figuring out how to buy food and medicine at the same time was sometimes a challenge. So let's stop there and move on. The food insecurity, though, was not born, even when you looked overall, by race ethnicity, was not born equally across all race ethnicity groups. And in this particular study, again, without it being a study about race ethnicity disparities, you can pull out that Black families who have employer-sponsored insurance and Latino Hispanic families are experiencing food insecurity at a higher rate than non-Hispanic, white, non-Hispanic, Asian employees. Alice. So I'd never heard of Alice until I was asked to speak to the Department of Health and Human Services Region 6 group. They said, we need you to talk about Alice. And I said, well, who's Alice? Well, Alice is a United Way acronym for asset limited, income constrained, and employed. I just described in that those 2 low cohorts, those 2 low groups, income groups, that's Alice. So Alice is all those men and women who get up every day and go to work, but they may have a food security issue on any given week, or they may have their car break down and not be able to fix it until the next paycheck, if even then. That's Alice. Alice is your child care worker, your mechanic, home health aide, store clerk, office assistant, and again, lots and lots of people that work in university systems are Alice. So I hope if there's one thing I left you with that maybe none of y'all knew was who was Alice. Now, this is a really interesting study that I sort of grasped and have used for many, many years. It was done by Sandro Galeo, who is the Dean of the School of Public Health at BU. And hold on a minute. Let me just say that I am personal friends of the Dean of your School of Public Health, Paul Irwin. And although I didn't get a chance to meet him in an office, yesterday he was my Uber driver. Just let you know, and I gave him 5 stars, just so you know that too. He was also really chatty, knew his stuff, and he drove a very good speed. So this was a study that looked at social determinants of health categories and attempted to attribute deaths by those categories. And you can read the methodology yourself. I just find it really interesting to look at this because it helps me get a sense of the magnitude that social determinants of health, unfavorable ones, have on mortality, at least through this way of analyzing. And I'll let you look at the numbers. Low education levels at the top of that list. And if it was compared to the causes of death I showed you a little while ago, it would be the number 4 cause of death even in 2021 or 2022 or 2023 for that matter. And I don't know that we put the energy in low education level and addressing that we put in lots of other things that are on that list. I work with the American Heart Association, and understanding what are the things that contribute to cardiovascular disease is really important. And you may or may not know this, but at least according to this particular analysis, hypertension is at the top of that list by a long shot. What it says to me is that if we can identify what it is and we can identify a way to address it, we ought to be doing that. And I think it's Willie Sutton when asked, why do you rob banks? That's where the money is. If I was trying to figure out how to prevent cardiovascular disease, hypertension is going to be on my list of a few things that I'm going to do for sure. But I also want you to see that number 6, interestingly, low education. Low education, at least according to this study, is above abdominal obesity, diabetes. I don't really believe that. Low grip strength and low physical activity. But the fact that it's there, top 10, says there may be some value in thinking about these social factors as not only describing the thing that we're interested in and helping us understand it, but helping us look for solutions to address those things. Life's Essential 8. I'm wearing my 8. Do you have any? Oh, you're gonna have one today. I got a bag full of them. Life's Essential 8 is AHA's definition, way to define cardiovascular health, and it's across 8 domains. 4 of them, I would say, are behaviors. I don't like the term lifestyle. When I think of lifestyle, I think of like country clubs and fancy cars, but that's the term we use. But lifestyle behavior would be sleep, healthy eating, physical activity, and not smoking. And when I say sleep, adequate sleep. So let's bring it all into positive. And then 4 health factors, all of which are to be either in the healthy range or in the normal range or control. And that would be weight, blood pressure, blood glucose, blood cholesterol. The bottom line is, I'm sure Paul has heard this thing talk 1,000,000 times from our friend Don Lloyd Jones, is that if you're good on those 8 things, you're set for life to live a longer, healthier life compared to people who are not good on those 8 things. And if you reach 50 years old, good on those 8 things, the likelihood of living to 80 and 90 is way, way high. Now, let's be clear. I get that those are 8 things and that not everybody can do those 8 things. And I'm a doc who took care of patients who would say, Doc, I want to do this, but either I can't afford the food or I got to take $2 to get to the supermarket. And so things that I can put in a closet and can last for weeks is better than things that might perish in a few days because I can't buy enough of those anyway. Or my neighborhood is not very safe. And I don't know how I'm gonna do physical activity. And I was talking to someone. I was talking to Dr. Lohr today, who was saying that's the opportunity to sit down with somebody and be creative with them about how to get physical activity. You can do it in your backyard. You can walk up and down the stairs if you have them. You can choose times of day where it's more safe. 8 o'clock in the morning, even in an unsafe neighborhood, is safer than 2 o'clock in the morning, as an example. But I just tell you that's life's essential aid. Life's essential aid has been intersectionalized. I'm gonna try to use that word as much as possible today. And what you can see is there's the 8, and at the top of the 8 in the whole are the 8 gears of life's essential aid that contribute to cardiovascular health. At the bottom part of that 8, this is the best way to capture this, is a socio-ecological model that says context matters. And if you are somebody where there's a lot of unfavorability there, your ability for the ability of those gears to turn is less than if the things are good there. And then on top is psychological well-being. And you can see that across the top there's psychological health. One thing that I would like to see there, if I had seen this before, is discrimination and perceived discrimination on the side of anxiety, anger, et cetera, and so on, called out for what they are. So chronic stress is what happens when you experience discrimination, among other things, but discrimination and perceived discrimination, I believe, need to be called out. Hypertension is prevalent. And this man right in front of me did a really great study that I have turned into a set of tables that I'm going to run through fairly quickly. Hypertension control in persons with hypertension varies by age, varies by sex, unfortunately varies by race, ethnicity. And we can see here that for Black persons, Asian persons, Hispanic persons, there is a lower level of control as compared to white persons, at least from this NHANES data, and Paul Munner is the person who was speaking of. In addition, this is why I've used this a lot, is as I try to do the use case or test case about how social determinants of health are affecting health outcomes. This is a quick way to do it. Look at the gradient of blood pressure control by level of education. Look at it by income level. Look at it by the kind of insurance that you have, and look at it by your relationship to a healthcare facility. And what I would say to you is that the most striking of all those numbers is at the very bottom of this table. And that is that if a person who's been diagnosed with hypertension has had no health care in the past 12 months, the likelihood of blood pressure control, 8%. All those other numbers bear paying attention to, particularly uninsured compared to any other kind of insurance. It tells me we ought to get people insured because we'll be able to make an incrementally important increase in blood pressure control, all things being what they are. But the 8% tells me that if we are doing programming in communities that are doing blood pressure screening, and the single first thing that's done isn't connecting someone to clinical care, you've just committed malpractice, in my opinion. We should not be doing health fairs that don't have as their objective to connect people to clinical care. Because in our communities, particularly among the uninsured, that 8% is going to be overrepresented. So that would be the other pearl I would leave you with. As you are doing community-based work, whether it's about prenatal care or about hypertension, connecting someone to clinical care is really, really important. And I'm a public health guy. Medicine and clinical care isn't everything, but it can buy you, it can buy you time while you do the other stuff. So while you get somebody to eat healthier and be physically active, has high blood pressure, you can reduce the likelihood that a bad thing is going to happen while you get them there. And for pregnant women, to get them under control, as the study that was led by Dr. Tita tells us, you can reduce the likelihood that bad things will happen by bringing blood pressure control to below 140 over 90. Apologize for the quality of my voice. This was an interesting slide, made more interesting by the conversation I had today with the Pollocks, who are looking at, if you look at the bottom little ellipse, looking at not just the psychosocial and environmental stressors, but the biological and psychological sequelae. Looking at those things characterizing the pathophysiology of stress between stress and disease is being done here at this institution. That's really exciting. We do have a guideline on blood pressure control. Blood pressure control that's systematized and standardized and protocolized results in improvements in care. And this is just to show that Kaiser Permanente took their blood pressure control from about 45% of their patients to what is now close to 90%. Putting protocols in place can be helpful. I'm not going to read this to you. What that last slide was referring to is a MAP framework. So again, being systematic about how you do things. The MAP framework is what we're using in the National Hypertension Control Initiative and in Target BP to make sure that validated devices are used for blood pressure measurement and that blood pressure technique is good. And oh, by the way, I think I heard this morning that there's yet another opinion that doctors know how to take blood pressures. No, we don't. And we should be doing it. And we should have a team do it basically. And we should at least confirm what it is we think we saw. Act rapidly is about overcoming clinical inertia, that tendency that we have to think magically that, well, let's just wait a couple of weeks. Maybe something's going to change. Well, no, it kind of doesn't change. And partnering with patients, providing patients with self-measured blood pressure devices, this particular instance, and perhaps pregnant persons should have those SMBPs and be able to monitor their own blood pressure. I'm going to move quickly just to say that Target BP touches 8 million people with type 2 hypertension. National Hypertension Control Initiative touches about 1.5 million people with type 2 hypertension. Stage 2 hypertension. I bring that up because infrastructure and footprint matter. These are both systematic, standardized, protocolized ways of trying to improve blood pressure control, allows for efficiencies, allows for comparability, allows for lessons learned. I've been warned. If you don't have one of these infographics, get one, take it with you anytime you have your blood pressure taken by a healthcare provider, and I promise you, they're doing it wrong a lot of the time. Algorithms to be part of that systematization and protocolization, really important. And I'm really close to the end here. Addressing and assessing social needs is important. And I can't stress enough how important it is to know and be able to systematically get from a patient that maybe they are having some difficulty paying their rent, or maybe they're having some difficulty buying food. And unless they're in a trusting environment, an assessment like this is very hard to do, but in a trusting environment, it can help that patient achieve an increased level of trust with you, that healthcare provider, but also help address what might be something that's getting in the way of achieving a health outcome. We've partnered with community-based organizations to do the work in the National Hypertension Control Initiative, a reminder that ecosystem matters. So when you do the social services screening and somebody needs rental assistance, at least in the institutions that I've been in, they didn't have that. But I refer folks to community-based organizations, and 2 that are here, I don't know if they're used in Birmingham. Find Help is this awesome platform that people can use on their own, or people can be walked through. Unitas is not quite as DIY, but Find Help is awesome. I encourage you to see if Find Help is in this community. Look it up for you. Just Find Help. You put in your zip code and then just see where that takes you. If we could provide that to people, that would be helpful. Okay, I'm going to come to the end here because there's evidence that better collected data can help. I'm going to tie it all together now. One is that doing all of these things that's captured in this framework, starting with the socio-political and economic context, doing what we can to address the social determinants of health that then can result in better outcomes as it relates more favorability as it relates to social determinants, can lead to the ability to positively modify risk factors and reduce the burden of cardiovascular disease and improve maternal health outcomes. Wrong button. I'm not going to talk about this. This is in the pre-pregnancy. It's meant to capture social determinants as well as the life course for the woman and the baby. This is capturing the life course again. This is in the Life's Essential 8 paper. It's just a reminder that cardiovascular health, Life's Essential 8, applies in every stage of life and in every stage of health all the way to disease. And if you've had a stroke and can get better on Life's Essential 8, that's good. And if you had a pregnancy and you can get good on Life's Essential 8, that's good. And if you haven't been pregnant and are good on the Life's Essential 8, that's better for your pregnancy and better for your baby. And I'm going to leave, I think this is the penultimate slide. We need systematized, standardized, protocolized, multi-pronged, multi-sectoral approaches to achieve health equity. And that involves all of us getting outside the walls that we operate in and working with others that are in the communities that we work in. Start with health equity as a goal. Health disparities has to always be characterized as completely an unacceptable thing that's a reflection of inequities in our society. And again, we need this systems approach to get it done. 2 quotes I want to share with you. This was said by Martin Luther King on April 3rd, 1968. We as a people will get to the promised land. And I believe that being systematic, being committed and systematic, we can get to where we want to get with health equity. And I close with a quote that I use the most these days. I'm not an optimist. I'm a very serious possibilist. And the truth is that we have all the tools in front of us. We have all the what's in front of us. And what we need is the how. How do we take what we know and make it work? I believe it's possible. I thank you for your attention. I apologize for going right up to the last possible second, but that freed me from having to answer questions. And thank you for what you do every single day to achieve health equity.
Thank you. I think we can still do about 5 minutes.
Okay.
Questions?
Can I?
Someone's talking.
There's some in the chat.
We're looking, yeah.
Dr. Sanchez, the question from the chat is, as researchers in the field, what do you believe are some gaps in blood pressure monitoring and Black maternal health care that can be filled by our projects?
So ask that question again.
The question comes from Caitlin. As researchers in the field, what do you believe are some gaps in blood pressure monitoring and Black maternal health care that can be filled by our projects? Maybe specific topics or experiences that aren't discussed.
Sure. So extending beyond the walls, I think, is really important. Understanding. So I'm a believer that using the infrastructure that's already being used is really important. I imagine that y'all are partnering with WIC as an example, and even with Medicaid as an example, so that all touch opportunities are leveraged. And I mentioned WIC because particularly around maternal mortality and the populations that I remember working with when I was in an MQHC, those were families that were eligible for WIC. And that's another touch point. And the degree to which thinking about that as a touch point where healthy messages are being delivered about healthy eating, there may be opportunity to do some of that, for example, blood pressure monitoring in that place, in those settings. That might not be, maybe let me frame this positively, that would be an appropriate place to do some affirmation of blood pressure monitoring. As an example, affirmation, of course, of healthy eating, affirmation of all of life's essential aid could happen in WIC to complement what is going on in the clinical care setting, and being thoughtful about what those touch points are, I think, is one way to add value to what you're already doing. Does that help? And actually, does anybody have any ideas? Because one thing I said earlier is there's 3 P's that describe me: poser, practitioner, a proselytizer. And so I pretend to know what I'm talking about, but it's everyone else's work that I'm repeating. So, but my lived experience has been leverage that existing infrastructure. And WIG is an obvious one in my opinion. Yes, ma'am.
So we're one of those states that did not expand Medicaid. And there are many patients who we talked about pre-pregnancy health optimization, and they fall in that no person land between adolescent Medicaid coverage and then pregnancy Medicaid coverage. So I can only assume that the American Heart Association is working on that front.
So I can go. Is there more to the question? Good, because so one of the things I love about working at the American Heart Association is that we are all about expanding Medicaid in every state where it's not expanded. And so I want to leave you with, we are around to help with that advocacy and that work. I think it was South Dakota. We were involved in the popular vote. That's an expansion state. North Carolina's on our kind of the list as next in line. But I would share with you that, look, you can't feel the pain that I feel because I'm from the state that has the highest uninsurance rate in the country, the highest number of uninsured people in the country. How many people live in Alabama?
4 million.
4?
Yeah.
There are more uninsured people in Texas than there are people in the entire state of Alabama. That is not something to be proud of. And so I'm not even invited to meetings anymore because when asked, what do we need to do in Texas? The first thing I say is expand Medicaid. And I'm seeing somebody with this Texas A&M. It is so disheartening that we are having to have these conversations when we are having conversations about being pro-life. There is nothing more pro-life than expanding Medicaid for everyone in all the states that we live in. So I don't know what more I can say. And the Heart Association has scientific statements that say we support expanded Medicaid in every state where it hasn't happened yet. Thank you so very much. Wally, you get the last question.
So I love this Hans Rosling, and what's the videos of Hans Rosling? They're fantastic. And I agree with you. This is very pertinent for this. You don't have to be an optimist to fix the problem in our state. You have to be a serious possibilist. You have to say, yes, we have the resources. In Zambia, in rural settings, the poorest areas of the world, essential newborn care is being done at home and is better care than in the US.
Amen. So thank you so very, very, very much for coming here. And to those who invited me, thank you for making the bill. Thank you, everybody. No,